I think we're almost. I think almost everyone's seated out. We'll start in 1 minute. Thank you. Double J, how are you? Good. Good afternoon, ladies and gentlemen. I make the time 3 o'clock, appointed time of our Board of Health meeting, and of course that will be followed by our June 27th council meeting. Housekeeping as usual. I just want to welcome members of council and staff and guests. There it is. If you have a cell phone and you could put it in silence mode, just a reminder that would help us. Our meetings, as always, are televised and web streamed, and our volunteer again, I say again, this evening is Judy Ann McCauley. And Judy Ann, thank you so much for all the time and effort you put in.
We track vaccinations in children, and the way that we look at who is covered and who isn't covered. And one of our issues in the health unit, of course, is this number of suspensions that we have every year because children are not fully vaccinated. This is something that we don't want to do, and we try our very best to get that number down, as we've reported previously. But the government's got to improve this now, because these vaccination records are going to be available to the public. They'll be able to go into the system towards the end of this year and have a look at their current status for their children and themselves, actually. And as an extension to that, I believe next year they're looking at allowing them to update their own records. And just to remind you once more that we rely in the health unit on parents reporting these vaccination status of their children to us, because it's not at present an initiative that's given to the people that give the vaccinations. So we're looking forward to improving our delivery of these services and hopefully reducing our number of suspensions. And hot off the press, I heard yesterday that in Yemen there are 208,000 cases of cholera, 35,000 cases per week being reported, and which is 86% of the whole country. So it's the largest significant outbreak that we've seen in the world for many, many years. So just for, if you're thinking of traveling, it's a place to avoid, I think. I think that's my report, Mr. Chair.
Thank you very much, sir. Well done. Are there any questions to the doctor at this time? Councillor Oliver, please. Thank you.
Thank you very much, Mr. Chairman. Thank you, Doctor, for your report. I do want to go back in on the Lyme disease item that you mentioned, and I, for one, if I can, would like to get another copy. I remember seeing it before, but I'm sure I've probably misplaced it, so maybe, Marlene, you could make note of that. But at the recent meeting of the Turkey Point Property Owners Association that Mayor Luke and I were at, there was a lot of discussion down in the Turkey Point community about Lyme disease, the continued risk associated with ticks, et cetera, et cetera. And I have spoken with our GM of Health and Social Services about this, and I'm wondering, Dr. Locke, if you feel there would be merit in our health unit and in Norfolk County pressuring the province to do something relative to standing water locations in the Turkey Point area and the prevalence of vegetation and therefore ticks associated with it. As one strategy in reducing the risk, in other words, of a larger tick population and therefore a higher potential for someone to contract Lyme disease. Is that something you are aware of that's being, if you like, supported in other health units at all where ticks are a problem, or is it something that you feel you could lend your support behind, taking that health-related approach rather than the other approaches that have been used on standing water problems in Turkey Point?
Yes, if I could come at that in a slightly different direction. One of the issues that we are facing at the moment is there's a lot of mixed messaging coming out from Public Health Ontario, the ministry, and also nationally concerning how we should treat and diagnose Lyme disease. One of the major issues at the present time is that PHO have put out a map very similar to the Health Canada map that was in your report here of tick areas. But unfortunately, one of the recommendations also coming forward is that even in these areas which are designated as tick-borne areas, the treatment of Lyme is variable, because what they're saying is that even though these may be tick areas, 20% of the ticks in an area that is designated need to be positive for Lyme disease before they would recommend acute care treatment. So it really means that we have to move from what we were doing secondary surveillance, which is having people bring in ticks for identification to get an understanding of how many black-legged ticks, which are the ones that carry Lyme disease, are in a particular area. So instead of going from that, which is a secondary form of surveillance, we should get into a primary surveillance, which is actually going out and dragging for ticks. Now, unfortunately, I tried to check with our senior environmental health inspector before I came, because we have talked about starting this in the fall of this year, and I don't know whether or not that's still planned, but certainly if we have money in the budget, we are going to be doing the active surveillance, getting into active surveillance, which I know doesn't address your exact question, but we are trying to move along, and yes, we would support getting a local picture, but the province is not involved in doing this at the moment. It's up to each individual health unit to bring up their own strategy for how they're going to deal with this. Because the important thing for me is what recommendations do we make to our primary care providers who are treating these cases coming in. So we really need to know that we know we're an endemic area, but what we don't know is what percentage of those ticks are carrying Lyme disease.
Thank you, Mr. Chairman. Thank you very much for that. Actually, I think it does relate very directly to my question in the sense of the idea of being proactive to go out and sample the intensity of the tick population and the percentage that may be carrying the factor for Lyme, I think is a really good idea, and I hope the Board of Health will support that if let's say, any special funding might be required to undertake such a testing protocol this fall. So that's good, thank you. We think we're a hot spot. This would verify whether in fact we are or not, and I guess if we are, would add some strength to us looking for help in various ways. Yes. So thank you.
Thank you. Councillor Columbus, please.
Yes, the long-standing issue at Turkey Point Beach, which is owned by the Ministry of Natural Resources, is the fact that there's a great deal of tall grass from the Marina Pier towards the business district. And it's been forever discussed at property owners, the business association meetings, and it's getting worse, where there's an influx of tourists coming in, and they actually, when the beach is full, they actually have to park down at the southwest end and walk through this tall grass to get to the beach. And I think what Councillor Oliver's kind of targeting is, it's too bad that we could not have the MNR cut that tall grass so that the ticks aren't in that habitat. If it was cut and groomed rather than just left to grow wild, it would eliminate the tick population. And I think if we could if you could lend a hand in writing a letter of support to the powers that be at the Ministry of Natural Resources or in the Ministry of Health, I think that would help and eliminate some of that threat of increasing tick population there. Is that right, Councillor Oliver?
Yeah, absolutely, Councillor. I think that would be the related benefit, if you like. But I truly believe the idea of sampling to see if the population under present vegetation conditions is relatively high, then I think that would just add further strength to asking the ministry to do something. So thanks for that.
Any other questions for our MOH? Again, thank you, Dr. Locke. I have before me a resolution. Wells has moved and Oliver has seconded that the update from the acting medical officer of health be received as information. Any discussion on that motion? Hearing none, those in favor? That is carried. Thank you. And I just forgot to mention at the onset of the Board of Health meeting, Roger Geisens will be here later. He has a personal issue that needs to be addressed, and he will be here between 4:30 and 5 o'clock. He predicts, so I meant to mention that first of the meeting. Thank you. Thank you, Dr. Locke. We're going to move on then, please. We have one more staff report. That is HSS 17-14. This is the Baby Friendly Initiative and Designation. And Marlene, I see you're here, and Susan is here. I'm just going to turn it over to you two and let you run with this, please.
Thank you, Mr. Mayor. This following report is on the Baby Friendly Initiative and Designation. It is for information for Council and the Board of Health, and also seeking support of the Board of Health for the completion of the Healthy Friendly Designation. I'm going to ask Ms. Taylor to introduce our presenters and to present the report to the Board of Health.
Thank you, Ms. Miranda. I do want to introduce this afternoon two of our staff members. We have Ms. Courtney Brooke-Laurie. She's on the right-hand side, closest to me, and she's one of our dietitians with the Public Health Unit, and also Ms. Linda Burville, who's one of our public health nurses. Both of these individuals have been working with our Baby Friendly Initiative and are going to walk you through the presentation this afternoon.
Certainly welcome you, Linda and Courtney, and I'll wait your presentation. Thank you.
Thank you very much. Thank you very much for giving us the opportunity to do this presentation. We did prepare the Board of Health report, and this presentation is going to elaborate on some of the points. This is actually an update on the Baby Friendly Initiative information that was presented several years ago to the Board of Health. But we just thought that we would give you some information because we are hopefully very close now to designation and thought we would let you know what's been happening. So this is going to be a review and update on the Baby Friendly Initiative process, which I will refer to as BFI going forward in this presentation, and talk about the next steps. So what is the Baby Friendly Initiative? It's a global program of the World Health Organization and UNICEF, and the Breastfeeding Committee of Canada actually is the governing body for the Baby Friendly Initiative. It encourages health services to optimize care provided to mothers and babies to allow them to initiate and continue breastfeeding for as long as they wish, but it also helps to give families the opportunity to make an informed decision. And I want to be very clear that whatever choice women make in a way to feed their baby, we support, so we educate and we support women in whatever method they choose. And that's important. So why was this implemented? So what happened was in 2011, the Ministry of Health and Long-Term Care decided to make the Baby Friendly Initiative designation a performance indicator. So that meant that all health units within the province of Ontario were required to work towards their baby-friendly designation. And the evidence, this was an evidence-based strategy to increase breastfeeding rates. And why did they, this actually shows our local rates, but The reason that they chose to do this in 2011 was because there was a dramatic increase in the rates of obesity and diabetes in children. So that was a big push, and that was why the health units were mandated to do this. If a woman breastfeeds exclusively for 6 months, exclusively meaning that the only other fluids that the baby gets will be medication and vitamin D, her baby will have a 24% less risk of obesity and diabetes as an adult. So these were very significant numbers. So if you look at our local breastfeeding rates, you can see that the initiation rate is about 85%. These are from 2014. And this is not uncommon. Women usually make the decision on how they're going to feed their babies before their babies are born. So there's usually a high initiation rate. But when you look at the number at 48 hours, which is when we are contacting mothers, because our program, HBHC and Maternal Child Health, we are mandated to call moms at 48 hours post-discharge to check in and see how things are going. So you can see a dramatic drop in those numbers. And then at 20, the number goes down to 20% at 6 months. So where we feel that we do the best work, or some of our best work, is educating the moms before they have their babies, so in prenatal class. And what I mean by educating is informing them of the benefits of breastfeeding, the risks associated with formula feeding. But if they have made a choice, then we support whatever choice they have. If they have decided to formula feed, we just make sure that they understand how to prepare it, how to prepare bottles in a safe manner. The other thing that we do, which is really important, we go into hospital, our nurses go into NGH Monday to Friday if there are any new babies. We go in, see the moms, make sure that if they are breastfeeding, that if they have any questions, we try to rectify them for them. We also let them know what resources are available in the community, and we also let them know that we will be calling them at 48 hours post-discharge. And we do that, sometimes it's not exactly, it may be a little bit longer if we get the information in on the weekend. But we do our very best to call moms within 48 hours. So these are the two places that I feel that we really can concentrate on, reassuring moms if they need any resources, if they need help, where they can get it. Okay? Now, there are reasons when you look at this, there are lots of reasons why the duration rates are low. Some of them are personal reasons. Some women decide that they just don't want to breastfeed. Perhaps they have a lot of children at home. It's too much trouble. They want to make a bottle for someone else to feed their baby. Maybe they're going back to work very early. So there certainly are, women who have been sexually abused often do not breastfeed. And so there certainly are many personal reasons that women choose not to breastfeed. But there are also populations which tend to be less likely to breastfeed. And that's not just for us, that's everywhere. These include women under 20 who've had a baby, women living in poverty, women who are obese, women with mental health issues, women who are substance abusers. So these are other reasons. We can't change those demographics, but it's good to know that, we like to try to treat the client as a whole person. So it's good to know that, what we're looking at and facing, keeping those things in mind when we're educating them. This is an example, and I don't think this clip's going to work, but what we did was, when we did our breastfeeding campaign, which we'll talk about in a minute, in October, we went out and asked mothers what their experience was like breastfeeding in the community. And this woman had a very unfortunate experience. She started to cry, saying that people, were not very nice to her. They said that she shouldn't be breastfeeding in public. This is something that we do try to encourage. We have these posters in all of our Norfolk and Haldimand County buildings that a woman can breastfeed anywhere, anytime, and she can be provided a private space in those buildings if she chooses so. So this is one example of a reason that a woman may not continue to breastfeed because of the reaction that she gets from the community, and these are things that we're trying to change. Okay. So what have we been doing? Well, the process of becoming designated is a 10-step process, and these steps are outlined in Appendix B of the report, and I won't go through all of them. We're just going to touch on a few of them. Some of them are certainly much more laborious than others. The first one is the internal document review. So what happens is all of the documents that we prepare for the public, and that includes fact sheets, our prenatal curriculum, everything that goes on our website, social media, all of those things, everything that we prepare has to be looked at by the Breastfeeding Committee of Canada to make sure that it doesn't go against the WHO code. So the WHO code tells us that we cannot give out formula samples, we cannot equate formula with breast milk in terms of benefits. So we are not allowed, for example, to go to conferences that are funded by companies that make formula. So it's a very labor-intensive process, but we've gone through all of them, and we then also have to update these documents every 2 years. And then community development projects is another one because we are encouraged to work with the community. And as I said earlier, there is a campaign that we run every October during National Breastfeeding Week, and it's a social media campaign, and it's been called, this is the third year for this one, it's called Adventures in Breastfeeding. So what we do, we work with our graphic designer and our other people at the health unit, and women can call in or, write in, tweet in, whatever, and give their comments about their adventures. Other women might comment, but the staff, so either a nurse or a dietitian, is assigned to the days during that campaign so that we can respond. It may not be a question, but just a response to those comments in a timely manner so that the clients know that we're interested. The other project here is the Breastfeeding Buddies. So this is a big community developed project with other community agencies, and this is a project that allows women to call a breastfeeding buddy who has been trained in the 20-hour breastfeeding course to talk to them about their experiences in breastfeeding. Maybe they have some questions. Some women just feel more comfortable talking to a peer than they do to a professional, but if a professional is required, that breastfeeding buddy, who also has the 20-hour breastfeeding course, will contact the nurse if there's anything that she feels that she would like to have dealt with by us. Me still? Okay. Last for me, I think, is data collection. So one of the other requirements is that we continue to collect data regarding our breastfeeding rates in the hopes that we are demonstrating that our breastfeeding rates are going up. So at the end of this year, 2017, we will have 3 years of data, which is required before we can have our assessment done by the Breastfeeding Committee of Canada. So we will have that done by the end of the year, and this will also need to be ongoing. Okay.
Thank you, Linda. So another part of our baby-friendly journey has been the policy development. As referenced in the report, since 2012, Haldeman Norfolk Health Unit has established 3 policies to help create supportive baby-friendly environments for the public as well as Norfolk County staff. The infant feeding policy referenced in the report acknowledges that breastfeeding is a normal part of everyday life and that Haldeman Norfolk Health Unit will provide a supportive environment to enable mothers who choose to breastfeed or pump, as well as provide support to women who decide not to breastfeed. With assistance from the health unit, Haldeman and Norfolk counties have both established community baby-friendly policies to ensure mothers and babies are welcome and accommodated to feed while visiting Haldeman and Norfolk County buildings. A family-friendly version of the community breastfeeding policy is pictured here on the slide and is posted in public areas around county buildings. So staff training, going back to the policy piece, sorry. As Linda mentioned, a woman who is breastfeeding and returning to work has a right under the Ontario Human Rights Commission to be accommodated in the workplace so that she can continue to breastfeed her baby if she chooses. Haldeman and Norfolk both have established policies to support breastfeeding in the workplace. These policies are intended to protect all mother and baby dyads regardless of their feeding decision. So staff training is another component of the baby-friendly designation. Knowledge and understanding of organizational policies impact attitudes and practices of healthcare practitioners. Therefore, education has been key and one of the most encompassing aspects of the baby-friendly initiative implementation. So staff training is role and team dependent. So what that means is that all staff are informed of the baby-friendly policies at corporate orientation, and health unit staff must complete an additional orientation training regarding the baby-friendly initiative. Staff, so like myself as a public health dietitian and Linda as a public health nurse, or others who have direct contact with clients must also complete a 20-hour breastfeeding course with 3 hours of observational practice. So in terms of next steps and where we're going here, we've come a long way on our baby-friendly journey and have a few milestones we are continuing to work towards. Details of the baby-friendly initiative pre-assessment site visit, which we anticipate for the fall of 2017, as well as the external assessment, are included in Appendix A of the report. So this slide just showcases some of the resources available in our community. And while we know breastfeeding is natural, it's not always easy. So sometimes part of the battle is knowing where and who you can turn to for support. So here on the slide, we have presented a few of the Haldeman Norfolk Health Unit specific breastfeeding supports, one of which includes one-on-one breastfeeding support from our public health nurses, as well as a number of services and programs listed that are available in the community that protect, promote, and support breastfeeding. So in summary, as a health unit, we will continue to work towards meeting the requirements of the Baby-Friendly Initiative designation and the Ministry of Health and Long-Term Care Performance Indicator. Haldeman and Norfolk will continue to protect, promote, and support informed decision-making and breastfeeding through staff education and public education, community collaboration, and infant feeding surveillance. So we thank you for your time and attention and are happy to answer any questions you may have.
We thank you, Linda and Courtney. Well done. Are there any questions from board members to these two ladies? Councillor Oliver, please.
Thank you, Mr. Chairman. Thank you, ladies, for the presentation. With respect to the follow-up, you mentioned that we make contact with the mother at approximately 48 hours after hospital discharge or within that time frame. And then after that initial contact, what sort of regular follow-up, if I could describe it that way, is there as part of this ongoing surveillance of the mother and child in terms of breastfeeding?
Thank you. Through the chair, thank you. Well, first of all, we contact the mothers with their consent, so a screen is done in the hospital to determine what their risk factors are in terms of their demographic or social situation, if they need any help with breastfeeding. We contact them with their, as I said, with their permission, and we have a conversation with them. So if it's a woman with who's her first baby, we will offer her a visit. If there are any concerns at all or questions about the breastfeeding or any kind of feeding or any concerns at all, whether it's her first baby or her third baby, we will go out to visit. Some women who are with risk meaning, as I said, that their situation, would certainly benefit from having some ongoing follow-up with a nurse and a family home visitor to help with parenting and those kinds of things. Those clients are then taken on as long-term clients, so they have a family home visitor going out. Sometimes it's weekly, depending on the need, but the follow-up depends on the client and the assessment made by the nurse, and the two of them decide what they need. And so it may only be a phone call, it may be they don't want to visit, but certainly some women, we do have to follow them for long-term, some for maybe just one visit. So it really is client dependent. Thank you.
Thank you. Anything further? Thank you very much, ladies. Well done.
Thank you very much.
Thank you.
Moved by Columbus and seconded by Oliver that staff report HSS 1714, this is the baby-friendly initiative and designation, be received as information. And further, that the Board of Health supports the Haldeman Norfolk Health Unit's completion of the baby-friendly designation in 2018. Discussion on the resolution. Hearing none, those in favor? Carried. Back to your agenda. Under communications, there are 4 items of communication. I'm going to go through them, deal with them one at a time. They're covered under one resolution, but the first item of communication is the memo from Kathy Heffer. She's our program manager of a maternal and child care team, an update on the health care in Southwest Norfolk. And Marlene, if I may, or Susan, an important memo, I think, based on the fact that we went through the 0.5 reduction in the nurse practitioner. Do you want to just make a comment on this? I think everything went really well, and you're satisfied where we are. Do you want to comment? I think this is important.
Yeah, thank you, Mr. Chair. So certainly we are more than satisfied. We've been continuing the relationship with some of our key stakeholders in this area, most specifically the Mennonite population. And in fact, we just had a meeting yesterday looking at how have things been going, have there been any ongoing concerns, or are there any gaps? So we continue to work very closely with them. To our knowledge, all of the women who have been in that population have been assigned or connected to a physician within their community or a midwife within their community. And so we've been very successful in our partnership with the local healthcare providers. I think the memo does walk through that we were concerned and we wanted to be sure that folks felt supported, that we weren't discontinuing a service and then walking away without that appropriate follow-up, and we will continue to have that relationship. As was in the most recent presentation just a few moments ago, you can see that even from a health unit perspective, we continue to offer services either through our Healthy Babies, Healthy Children program, through our immunization program, through our dental services program, our school health, and our public health nurses. So we will continue to monitor, we'll continue our partnerships, and continue to evolve the supports that are there.
Thank you very much. Anything on this? Councillor Black, Mr. Black?
Yes, Mr. Chairman, through you to Susan. I know we had a deputation, and a lady was from a Poverty Action Partnership, Haldeman Norfolk, and they were concerned about the reduction in this service. And I believe you've probably met with them personally, and I'm just wondering, probably you've given them all of this information, but I'm just wondering, have you?
Through you, Mr. Did I turn on or off? Yeah, okay, sorry. Through you, Mr. Chair, we have certainly met with the Poverty Action Partnership Group, and we have continued to have those discussions. And in fact, 2 of the individuals who were present for that deputation are actually part of the ongoing working group that we have. We actually are fostering a very positive relationship there, I believe.
Well, I would imagine that this would probably make them happy. So, and you've given them access to all the information that you've given us here, I would imagine. Good. Thank you very much.
Any further questions? Item B is from Ralph Walton, the Regional Clerk Director from the Durham region, and this is some correspondence and letters to the ministry looking for more funding for our adult and older adult oral health. Much needed funding, but only so much. I think it's Lambton in there. One of them said 9 years is a long time to wait. Anything on that? I'll just keep Councillor Mr. Columbus, sorry.
Yes, Mr. Chairman, should we be sending something off? First, I'd like to ask Marlene if we are short on funds in this area, the Haldeman Norfolk Health Unit, and if we are, should we be actually sending a letter along to the Ontario government, to those various ministries involved with this programs?
Thank you, Mr. Mayor, to the councillor. Just related to the oral health for adult provision, if you recall, as we were going through the budget deliberations, there was a new budget initiative that was presented in a deputation where council actually did approve some additional funding, and through our discretionary funding, as of June the 1st, we are offering some adult preventative care for this population if they're eligible. So we have locally provided increased access to dental care for our adult population, and we are willing and able to also support any communication moving forward to the ministry to encourage that ongoing provincial funding.
So I guess what you're saying is we did add some money in the budget, levy dollars?
Yeah. Through the mayor, yes, we did.
And you think that we should be sending off a letter to the various ministries involved?
Through the mayor, yeah, we could support that letter moving forward to support some provincial funding to support ongoing dental work for our adult population in need.
So, Mr. Chairman, would that be in order to give direction?
My suggestion is if the board gives me direction along with staff to send that letter on behalf of the board to the various ministries, including Minister Hoskins, I would say a show of hands to support that at this time, if you will, please. I think I got direction.
Okay, thank you.
So we will do that, and we will certainly include a copy of that letter in the correspondence in the future. Okay?
Thank you.
So we have direction, and we shall do that. Anything else on this item 2? I'll go on then, please, to item 3, the information in here on opioid addiction and overdose, and certainly what I got from this correspondence was the need for physicians to make their patients well aware of the possibilities of addiction and overuse. And finally, number D, Ralph Walton, also from Durham Region, Vaccine Preventable Diseases Program funding. Anything on these items? Go ahead, Mr. Oliver, please.
Thank you, Mr. Chairman. Back on the opioid addiction one, I remember a few weeks ago when we had a staff presentation on this problem within our two county communities, and the fact that physicians in our two counties were, I think, either among the highest or the highest in the province in terms of the numbers of prescriptions of opioid medications being done. And I remember council asked or directed that staff make that statistic available to all the doctors, physicians in our county. I'm just asking staff if that has happened yet, and if not, could we reinforce that that's something that I think staff told us at the time the doctors may or may not be aware that we are the highest prescribing counties in the province. So has it been done, and if not, please do.
Through the mayor to Councillor Oliver, specifically to the physicians, we have not, but we can definitely do that. We have been doing an aggressive campaign of providing this information. We have had 2 community forums for information to the community, both here in Simcoe earlier this month and also in Dunnville. And staff are also presenting to the senior directors of our community from a healthcare perspective tomorrow, actually. So we'll continue on that endeavor of educating, and we will definitely provide those statistics to our local physician partners.
And very good. Anything further on these 4 items? Moved by Member Wells, seconded by Member Oliver, that the correspondence items A through D be received as information. Anything further on the motion? Those in favor? Thank you, gentlemen. That is carried. Any other business to come before Board of Health this afternoon? Under the closed session, Member Wells has moved, Member Oliver has seconded that the Board of Health move into a closed session at 3:46 PM pursuant to Sections 239B and D, as the subject matter pertains to personnel matters respecting identifiable individuals, including employees of the municipality or local boards, labor relations, or employee negotiations. Those in favor of moving into closed session, that is carried. We will now move to closed session. If you want to bring your memo with you, that may help. Thank you.